Good morning to you all. So I'll be talking about optimizing hemodynamics, use of inotropes and vasopressors in word setup. So though I didn't have much choice in the topic because the KSM secretary just called me and told that I have to do inotropes. So that is why I'm doing this. And also it is important as well. As I said, a lot of words are now in word setup. We are using inotropes. So it's not going to be a lecture anyway. We have a few cases that I'm discussing with you all, and probably I'll be discussing with myself. But anyway, we'll be talking about this today. So my objectives are to tell you all what are inotropes and vasopressors and how to select which inotropes in various situations and any other special concerns using inotropes and vasopressors. So inotropes and vasopressors, they are very important drugs and widely used in health sector. And they are potentially actually life-saving medications. That is why we all need to know about this inotropes. So we have to use them with cautious and mostly used as infusions. So our aim is to optimize hemodynamics. So hemodynamics deals with our cardiovascular system. Our end results should be whatever we do to maintain organ blood flow or the perfusion to the organs. So which is mainly started at the, should start at heart. And then there are several terms that are important. We are talking about preload, afterload, and contractility of the heart in order to maintain the circulation. And then heart rate, stroke volume is important, and which leads to our cardiac output. And then we talk about arterial pressure, and this pressure determines the organ blood flow, and hence the blood flow happens to the end organs. So our aim is to keep this perfusion going. So how do we know that the perfusion is happening? So we have to look at the microcirculation or at the organ level. So since we can't see it from our eye, so we are based on these parameters or these three organs, which are the windows to our microcirculation. So might have heard about this microcirculation in trauma, sepsis, any other critically ill situations. So if you see a patient who's deteriorating in the ward or who's not very well, so just go through these parameters, check whether the patient's conscious level is all right. So brain is one of the organs which affect first. So if your patient's conscious level is not okay, so it might have many reasons. But could be the perfusion is not adequate. And then we have the urine output or the kidney. Kidney actually blood flow is maintained up to some extent with all these compensatory mechanisms. So it's the brain will be the first one to show, and kidney might take some time. Skin is the same, so which is not an essential organ. So blood flow will diverted from skin to other organs. So with these three, you can get an idea about the organ perfusion. So we use so many names for all these drugs. So we know there are drugs like adrenaline, noradrenaline, and all that. We usually call them inotropes, but it is not correct. So it can be inotropes or vasopressors, inodilators, chronotropes, lucitropes, and again chronotropes. And so these names you have to know, but maybe not all, but the most important ones. But as I told you, we usually call them inotropes. So actually, what is an inotrope? Inotrope is a drug that deals with cardiac contractility. So contractility is how forceful is your heart is pumping. Okay, so we usually, your inotropes drugs can be positive or negative, but we generally call inotropes are to the ones which are positively inotropic. Okay, so these inotropic drugs should be able to increase your stroke volume because the force of contraction is high. So adrenaline is one of the inotropes, so is dopamine and dobutamine. So their main action is to increase the contractility of the heart. So they are inotropes, but we still call them vasopressors. But vasopressors are something, we call them inotropes. So vasopressors are something different. Vasopressors, they act on mainly the peripheral vasculature to get your vessels constrict. So the important thing or the important vessels we are considering here is the arterioles. Okay, so it's the arteriolar vasoconstriction which takes your blood pressure, which increases your blood pressures. So the drugs that acts on these peripheral vasculature is known as vasopressors. So the commonly used ones are the noradrenaline and metaraminol. So we do have metaraminol, so we should start using it, and then vasopressin. So they are vasoconstrictors. So those are the things, two drugs. One is inotrope, the other one is vasopressors, which are like two basic categories of vasoactive drugs. Then there is a concept called half-life. Half-life, you all know, it's a if pharmacologically speaking, it's a little complicated thing, but what you all have to know is it's the time taken for the concentration of a drug to become half. And the important thing is after 4 or 5 half-lives, that we can assume that the action of the drug is no longer there. So important thing about inotropes and vasopressors, their half-life is very short. So therefore, their duration of action is also very small. So the drugs like these inotropes, there is no point in giving as boluses. Okay, so you have to have them as infusions. Just giving one dose will not be enough because they have a very short half-life. It's like 2 to 3 minutes. That is why you might have seen all these inotropes are given as infusions. So when to use inotropes and vasopressors? So there are several questions that you should ask about the patient to identify whether this patient is having enough perfusion or whether this patient is in shock situation. Okay, so there are several questions. As I told you, you can look at these microvasculature or the windows, urine output, conscious levels. And if you have blood gases, you can see whether what's the pH is like and also what's the lactate is like. And then whether your hypovolemia is corrected and whether your cardiac output is adequate. So if this is not enough, you have to decide on that your patient needs support, something other than fluids. Okay, so then you have to know what you're going to do with these patients. So your aim of your inotrope or vasopressor therapy is to improve your organ and tissue perfusion, and just by doing that, you will observe a clearing of lactic acidosis. So just look at this case. So this patient is a 45-year-old male patient who was admitted to the surgical ward following a trauma to neck, which was sustained during shallow water diving. When he brought to the hospital, it was found that he had a motor and sensory weakness below C5 spinal level. And then after trauma CT or CT, he was diagnosed to have a spinal cord injury at the level of C5. Okay. And then you do the fluid resuscitation, and then you think about any other injuries of this patient, and then found to have no other injuries, but this patient was continuously found to be hypotensive. Okay, so now if your patient is hypotensive without any other cause, you have to think this patient is on shock or not. Okay, so if your blood pressure is low, your organ perfusion is going to be low. So you observe it for some time and you can diagnose whether this patient is having a shock or not. So what kind of a shock is this? If this is a shock at all? Yeah, it is a neurogenic shock. So neurogenic shock is something that you observe secondary to spinal cord injury or any diseases in the spinal cord. So what happens is the spinal cord, there is a part that sympathetic nerve supply is also there. When you don't have the sympathetic tone, you lost all the sympathetic tone and there will be peripheral vasodilatation. So that is why you get a neurogenic shock. So your all vessels are dilated and your circulation is now in a bigger volume. Okay. And in addition to that, your vagal tone will be uninhibited. Usually there is a balance between the parasympathetic and sympathetic activity. Now there is no sympathetic activity, so the vagal tone is going to go up. Okay, and this is common in high spinal cord injury. So you will see spinal cord injuries above C6. Okay, would you use inotropes or vasopressors in this condition at ward setup? So this patient is still in the ward. Yeah, you might have to. Okay, so Your initial stabilization is you're going to give some fluids and see, because as I told you, there is vasodilatation and filling might be adequate for these patients, and just fill and see whether this is adequate. Of course, this patient has a higher spinal cord injury, so might have breathing difficulties as well, which need any other form of supports. But we are talking about the neurogenic shock only. So if your hypotension persists, then you have to have something that will constrict your peripheral vasculature. There, your vasopressors come into play. Okay, so usually after the pathology is that this will last for some time, and about 1 week or so, this is going to recover. But until that time, you're going to support, because you're going to prevent your secondary injuries to the spinal cord. So you have to have a higher blood pressure in these patients to prevent secondary injuries. Usually in an injury like this, you don't expect any other injuries. You have to exclude head injury anyway. But of course, if it is a straightforward injury, so it's just an isolated spinal cord injury. So now, depending on the pathology and the pathophysiology, what happens in the neurogenic shock. So your first line would be to give a vasoconstrictor, so which will be noradrenaline. Usually, if you want to give a vasoconstrictor, noradrenaline is your first line of drug. Okay, and you can use adrenaline as a second line vasopressor, or phenylephrine is also can be used, but there is a little problem in using these drugs. So now I told you there will be uninhibited or unopposed vagal activity as well. So your patients will be bradycardic generally. So if you use a drug like phenylephrine, which causes bradycardia, it might affect them in a bad way. So therefore, you have to be cautious in managing these patients. Again, you have to monitor those patients, because you're playing with the sympathetic and parasympathetic nervous system and the balance between them. So close monitoring of these patients are important. Okay, so that is your neurogenic shock. Okay, a little bit about neurogenic and spinal shocks. So spinal shock is not a shock. I mean, like a related to the cardiovascular, something related to the cardiovascular system. It is just a term. So your neurogenic shock is the shock where your hemodynamic instability occurs because your sympathetic tone is no longer there. But it is a part of your spinal shock syndrome. Okay, so spinal shock is something where you actually describes the situation where lack of motor and sensory innervations in a patient. So it's not actually anything to do with the cardiovascular system. And this can be temporary or permanent. Okay, so that is your neurogenic shock patient you might come across in surgical wards. Okay, so this is your second case. So it's in a simple form. So it's a 74-year-old patient with hypertension and who presents with acute onset chest pain and difficulty in breathing. And you do a 12-lead ECG and you do a diagnosis of anterolateral MI of this patient. And then you do some careful titrated fluid boluses, but still your blood pressure is found to be low. Okay, so would you consider this as a shock? Blood pressure low. So you have to do an examination again to have a look at the other systems as well, the microcirculation. And if that is also affected, if your patient is very cold and persistently low blood pressure despite fluids, then you can consider it as a shock state. So would you consider inotropes or vasopressor for this patient? So what kind of a shock, if you're thinking of a shock, is this? Yeah, it is a cardiogenic shock. So would you consider inotropes or vasopressors? Definitely. Okay. So in the cardiogenic shock, first line, any kind of shock, you have to think about the fluid status. So you starting inotropes in a fluid deficit patient doesn't make any sense. You have to fill the patient first, then only you support your circulation. Okay, so even in cardiogenic shock, you're allowed to give titrated fluid boluses because the patient has to be in a monitored situation. Okay, so in this cardiogenic shock, there is myocardial dysfunction and your cardiac output is affected. Stroke volume may be affected, and maybe sometimes the heart rate, depending on where your ischemia occurs. So initial management, you're allowed to give fluid challenges, but not to overload these patients. So once you think the fluid status is all right, and if you give more fluids, the patient will deteriorate. If you think like that, you're okay to start on a vasopressor or inotrope. So idea is to support your heart. Okay, so persistent hypotension requires adding inotropes and vasopressors. So it seems like adding a inotrope or something to support your heart will be beneficial for this patient. So that is what we usually do. We add either a dobutamine or a dopamine. So dopamine has been the drug of choice for like many years. It's still being used, and dobutamine also be used in most of the medical boards for this purpose. But adding noradrenaline, this is what I want to highlight. So that is also indicated in these patients. So noradrenaline is a vasopressor where it vasoconstrict. So what it does here is that it increases the diastolic pressure, and when your diastolic pressure increases, your myocardial blood supply will be restored, because the blood supply to the heart happens during the diastole. So you have to increase your diastolic blood pressure. So in cardiogenic shock also, there's a place for vasopressors as well as inotropes. Okay, so it's something like this. So if you look at this, people who are familiar with echo pictures. So the first one is where your heart pumps before you start inotropes, and second one is after the same patient after. Those are that is how it is supported. The myocardium, the contractility goes up. Okay, so it's the same, another view of the myocardium. So first one before starting, and second one ability improves in these patients. Okay, so that's what starting an inotrope will do to your myocardium. Okay, the third case. So this one is a 43-year-old patient who was admitted to surgical casualty unit following a road traffic admission. Road traffic accident. So on admission, this patient was found to be pale, and you have a blood pressure of 80 by 60 and pulse rate of 140 and low volume 3D pulse. So you do a fast scan and you see definitely there's free fluids and patient is pale. So there is definitely a bleeding going on. So you start activate your massive transfusion protocol as well. Now the blood is coming in and you're trying to transfuse this patient. But despite that, patient's systolic blood pressure is being low throughout. Now, would you start an inotrope in this patient? So what kind of a shock is this? Hypovolemic or hemorrhagic shock. Okay, so in hemorrhagic shock, would you consider inotropes and vasopressors? So now I told you, you have to fill your circulation before starting on inotropes. Now, this is a different situation where whatever you do, patient is still bleeding. So patient is going to lose blood, whatever you do, until a proper surgery is done. Now, whatever we do, it will take about 1 to 2 hours to take the patient to theater and do a proper surgery, damage control surgery. So until that time, so our question is to whether we need to start on an inotrope or a vasopressor. Now think if your patient is in a peripheral center which need to be transferred here. So during transfer, would you start inotropes or vasopressors? So that is the question. So this has been like debated for many years, whether to start inotropes or not. But our idea is to keep your mean arterial pressure high, just to keep the blood pressure going to the important organs like brain and the heart. Okay, so now what they say is you can start vasopressors because it is explained. Now when you're bleeding, your sympathetic system get activated and then it becomes overwhelmed. After some time it's fully activated, it can't activate anymore. Okay, in that situation, actually when your blood still the volume circulating volume is not enough, you can still start on inotropes or a vasopressor in this patient. So vasopressor would be your first choice, but in the patient, because this patient is unlikely to have any cardiac issues, it's a 43-year-old patient. But if you, after sometimes, if you suspect any cardiac issues also, then with that, you can start on a inotrope as well. Okay, so it is just to support the circulation system, but your definitive management will be to give blood and resuscitate and stop the bleeding. So again, you're using the noradrenaline as the first choice, and it's used because of its sympathetic its action on sympathetic system. Then if you need inotropes, you can use a dobutamine and adrenaline. So I used adrenaline as a vasopressor as well as the inotropes both, because it has both actions. It can be inotropic sometimes, can be act as a vasopressor also. Okay. So next case, so we have a 56-year-old patient with diabetes mellitus presented with a 3-day history of fever, dysuria, and low abdominal pain. And GCS was 15 and a blood pressure of 80/40 and a pulse rate of 120 with the prolonged capillary refilling time. So this is your normal blood gas, which shows metabolic acidosis with high lactate. Now looking at this history and the background and all that, we can say this is a kind of patient is kind of in a septic shock because the blood pressure is already low. Okay, so septic shock, what kind of a shock is that? It's a distributive kind of a shock. So it's definitely a shock. It's the commonest shock that we encounter in day-to-day practice in medical wards, surgical wards, and in everywhere. So it is one of the commonest reasons why we start inotropes or vasopressors in our ward setup. Okay, so this is the picture that you will see in this patient. Okay, about little definitions. It's a life-threatening dysfunction of vital organs, and septic shock is when it is accompanied by the circulatory dysfunction, and it is a life-threatening situation. Okay. So you have to, in all the new guidelines, suggest early, like this is about 1 hour, 1 bundle, and it's a golden hour. You have to act very fast. And in this golden hour, starting inotropes is also included now. If your patient does not respond to fluids, you're going to start them on inotrope. So in distributive shock, shock like septic shock, your fluid therapy is the first line of management. And then you keep on resuscitating with the fluid. But within that 1 hour, if your patient is not going to improve with fluid, then you're going to start vasopressors in this patient. So this in distributive shock also, the pathophysiology is that there is generalized vasodilatation. So you're going to constrict your vasculature and you're using a vasopressor in this situation. So this everybody knows, noradrenaline is the drug of choice or the first line of vasopressor that we are going to use in patients with septic shock. And second line will be your adrenaline and vasopressin. So vasopressin, now we are talking about the ward setup here now. So we usually don't use vasopressin in ward setup. Vasopressin is a very potent vasoconstrictor and is usually the titrated, the doses are not titrated as other vasoactive agents. So most of the time wards are not familiar with it. So it is all right not to start this at the ward setup. So starting noradrenaline and adrenaline is enough. And if your patient requires another vasopressor like vasopressin, the patient should not be in the ward. So he has to be in somewhere else. Okay. So definitely don't worry about vasopressin. Just try to find somewhere to transfer your patient. Okay, the next case. So the 23-year-old male was found collapsed in the medical ward following administration of dose of intravenous coamoxiclav. So which happened during past few months. And you see a generalized body rash and hypotension in this patient. And blood pressure was 70/40. And you diagnose the patient as this is an anaphylaxis and this is an anaphylactic shock. Again, what kind of a shock? Distributive kind of a shock. Okay, and there will be widespread vasodilatation secondary to mast cell degranulation, and there will be histamine release. So that is why your anaphylaxis is happening. So what is the drug of choice? It is adrenaline. Okay, so why adrenaline? Why not noradrenaline? So that is the other question that we are going to answer, because there is widespread vasodilatation. So what is justifiable is to use a vasopressor. Anyway, the best vasopressor you have is noradrenaline, but here we are going to use adrenaline. So the question is why adrenaline and not noradrenaline? Okay, so it is little different in the management of anaphylaxis. So your action of adrenaline actually is dose dependent. So I told you we are not giving any inotropes as boluses. Everything has to be given as a infusion. But here it's an exception where you give adrenaline as a bolus. Okay, IM 0.5 milligram is a very high dose. Okay, so we usually use almost half of the vial. Usually half of the vial will be used in hours in other kind of shots during hours. Okay, but here you're going to give it as a bolus. When you give a very high dose of a vasopressor like this, the effects actually changes. So it will be it will be a very potent and very strong vasoconstrictor if you give adrenaline in a very high dose. Okay, so now there is vasodilatation which is happening very, very quickly in anaphylaxis. So you have to have something which acts quickly as well. So that is why you give adrenaline in a very high dose. In addition, it has other advantages, like it reduces mast cell degranulation and reduce edema as well. Okay, and in addition to that, it increases the pressure in the aortic root as well, because it's a very potent vasoconstrictor now, because you are giving it in a very high dose, and it increases the blood supply to the myocardium. So that is why we use adrenaline, not noradrenaline, in anaphylaxis. Even if you find patients with refractory anaphylaxis, your infusion is usually, the guidelines suggest adrenaline infusions. I know we are giving noradrenaline infusions in some situations, but if you find persistently hypotensive, the adrenaline is the drug of choice. And the last case, so this is a 72-year-old patient who was found unresponsive in the ward and no pulse, no respiration. And you confirm this as a cardiac arrest, and then you go in these algorithms and you do a rhythm check. You find patient is in asystole, and then you do cardiac massage, which is continuing your cardiac massage. Okay, so we give adrenaline in cardiac arrest situations in pulseless electrical activity, asystole, or after the third shock in VT and VF. So it is the same thing. So you have to have something increasing the aortic root pressure. So that is how the blood supply is continuing when you are giving cardiac massage. Okay, and with the adrenaline, it causes widespread vasoconstriction. So it is better than noradrenaline in this situation. And noradrenaline, there are no dose calculations to give as boluses. In some countries, like in some of the American guidelines, they don't use adrenaline, they use vasopressin. So it's the same action. So you can't really do a randomized control trial or something to see whether the vasopressin or adrenaline is better, because it's a very critical situation. You're not going to take any chances. So it has been adrenaline in our country. So we are continuing as adrenaline. So that is how you select your inotropes or vasopressors in patients who are critically ill, and until you transfer to a ICU or a HDU, you're going to select your inotropes depending on the pathology the patient is having. So we were talking about when to and what to use, and then how to use and how long to use. We'll just have a look. So in your inotropes, I told you they are short acting, whether you have to give a bolus or an infusion. So the exceptions for boluses are the cardiac arrest situations and the anaphylaxis, and rest we are not going to do any boluses. Rest has to be through infusions. And your infusions has to be going through syringe pumps. So it wasn't initially, I know the people put like adrenaline vials to salines and they run. So we have done it too, but now of course most of the wards are equipped with these syringe pumps, and it is very easy to handle. And the nurses are well trained. So if you are using inotropes or vasopressors in patients, try to use these syringe pumps. So it will be very accurate what you are giving to the patients. Because nurses are also very trained now. And then you have to use a dedicated lumen, and then you have to tell the nurses what the targets are. So you can't just start on an inotrope and then next hour the blood pressure is 200 and 120, because you haven't advised the nurses what to do. They will continue on the same infusion. So they know what to do, like come down on how to come down on infusions and things. So we just have to give them a target, either a mean arterial blood pressure or your systolic blood pressure, so they can process their infusions. Then you have to titrate always, because their action is unpredictable. It's just dose in one patient may not be the same dose in the other patient. So understand the dose of your patient, which needs, and then slowly titrate. You can go up or go down because you're making a very diluted solution. So you have space to come up and down on the infusions. It's about the use of central lines. Yes, definitely. These has to be gone through central lines, your inotropes and vasopressors. Why? Because they are irritable to veins. They are vasoconstrictors. So whatever they do, they will constrict all the veins on the way when they are going when you're giving it through the vessel. But the problem with the ultrasound, so the central line is you need expertise to insert, and now current recommendation is you have to use a ultrasound machine to insert wherever you're going to insert these patients. So those are the safety measures. So it will take some time for you to insert these lines. So most of the guidelines suggest now peripheral administration is all right for a shorter period, but not for like 2-3 days. So we have seen patients who have been on noradrenaline for 2-3 days in the wards through a peripheral cannulas. So which should not be doing, which should not be happening. And if your patient is the area that the patient is receiving the vasopressor looks well after 2 days, that means patient has not got the inotrope. Because if that has happened, it should be necrosed if the patient got the right concentration. So make sure those things has to be avoided. So in emergency situations, shorter durations you can use. So or like until your patient is transferred to ICU or an HDU. So these what happens when your noradrenaline extravasate. So you can have necrosis of skin as well as subcutaneous tissue if this noradrenaline extravasate from these vessels. So again, the exceptions to give noradrenaline through large bore cannulas. If you can insert an external jugular line, that is better because it's still a large vein, or at least in the cubital fossa. So it is indicated in the management of sepsis. I told you, you have to start it in the first hour. So you might not have time to insert a central venous line. So there you're supposed to start on a peripheral noradrenaline in these patients. And then dobutamine, which has been given through peripheral lines for a longer period. And it has been shown to be safe as well in cardiac units where you have unstable patients. We can use it from the peripheral line. So it's a safe option that you have. Again, guideline does not suggest to use them for a longer period. What they say is your patients may be too unstable to lie down. So rather than lying them down, you just continue your inotropes to the dobutamine through the peripheral line, so which is actually understandable. Okay, so those are the exceptions where you can use inotropes and vasopressors from the peripheral lines. So you have to know when to stop your inotropes. Now, if you identify your patients in shock, and then you start the patients on inotropes, it is unlikely that you're going to stop in the ward setup itself. So if your patient is having increasing inotropes, you definitely need to transfer this patient to a higher level of care, that is ICU or HDU. So don't keep these patients in the ward. Okay, I know the ICU beds are tight, so at least transfer to a HDU bed or a bed where you can monitor these patients. So continuous blood pressure monitoring will be there, and therefore you can come down on the doses, and then later you can wean off completely your inotropes. Okay, so that is when you have to stop your inotropes. Then after your patient is improving, or if your patient is dead, then you can stop your inotropes. So that is what all I have to tell about the inotropes, the practice in the ward setup. So inotropes are vasopressors. They are very highly potent drugs, and you need to start promptly at ward level. So you have to know how to start, what to start, and when to start the inotrope. And then you have to use the choice. Choice should be depends on the indication of shock, and continuous monitoring is mandatory, and escalate to higher level of care when is necessary. Thank you very much.
Ashani, any questions from the audience?
Ashani, I would like to congratulate you on the excellent lecture. My question is regard to the anaphylaxis management. So over the years, we have seen that there have been different views on the number of policies of adrenaline that we need prior to starting an infusion. So for the benefit of the students, could you explain the maximum number of policies of IV adrenaline you could give prior to starting an infusion?
Yes, thank you for the question. So it's like this. So if your first bolus doesn't work, you can give another bolus. And then if that is also not working, there is no actually a limited number. So various guidelines says various things. But if your patient does not improve, which means the patient is going into a refractory state of anaphylaxis, so you can start on an infusion of adrenaline, or you can look for an alternative cause for why this is the blood pressure is low. If you are asked for a number, I don't think there is a number like that. So correct me if I'm wrong, Nishan. So about the number of boluses. So you can give if it is not responding in an acute setup.